for joining us today. This is our kickoff day of the Triton Leaders Conference 2023. My name is Risa Farrell. My pronouns are she, her, hers, and I and the panelists today are so thrilled to welcome you to this special session addressing the social drivers of health through CalAIM. So thank you very much for joining us. We know you had options today, and we know that this will be a really impactful and vibrant discussion today. So we're really thrilled to have this ongoing conversation with you all. It's going to be interactive. It's going to be a really engaging session. And so as we start, I wanted to begin with a little bit of housekeeping just to make sure that we all feel as comfortable as possible. If you are not a panelist, please do mute your microphone unless you are speaking. So please be sure that we want to eliminate as much background distracting noise as possible. We also will have a dedicated question and answer time at the end of today's session. So when we get to that point, if you have questions for our panelists at the end, please familiarize yourself with the reactions button at the bottom of your screen. There's a raise your hand feature so that you can identify yourself as someone with a question, and we can be sure to call on you in the order that you raised your hand. So we'll have that as our frame of metrics or working at the end. However, we'll have a really interactive chat throughout today's session. So our panelists will be moderating and responding to questions in the chat. So if you do have any questions during the session, please don't hesitate to drop your questions into the chat, talk amongst each other. We really encourage that engagement. And then again, at the end, you'll be able to raise your hand with that reaction emoji so that you can actually come off mic and talk to the panelists directly. Lastly, we will always abide by the UC San Diego principles of community, which are here. The goals of these principles are to provide fair treatment for faculty, staff, and students here at UC San Diego and amongst our partner communities. We want to encourage a climate of fairness, cooperation, and professionalism in all that we do. And so we're really thrilled to really abide by a belief in fostering inclusiveness, respect, and a welcoming environment too. So we're excited to promote that collaborative attitude and actions today in our chat, in our session, and in our Q&A. And so we wanted to affirm these right at the beginning of our session and ask that we all do abide by these throughout today. So with no further ado, it is my absolute joy and privilege to turn this session over to our panelists. I'm going to let you all introduce yourselves and kick us off. Thank you so much for being here to you all.
Thank you, Risa. Hi, everyone. I'm Tony Fiori, 1998 graduate of UC San Diego, proud Triton. Wonderful to be here with all of you calling in from the beautiful and sunny but cold East Coast at the moment, and jealous all of you who are in San Diego or the warmer West Coast climates on this beautiful winter day. We have an incredible panel that we've pulled together to talk about very important topics of social drivers of health, particularly around the innovation that's happening in California. My colleague, Lori Houston-Floyd, and I will be managing the conversation and our panelist discussion this afternoon. Lori and I work for Medi-Cal Health. We're an integrated law and consulting professional services firm that has a significant healthcare practice. And a big piece of our healthcare practice is actually working with states and providers, payers, the federal government around the innovation that's happening in the social drivers of health space, particularly as it's focused on addressing health disparities. So we're excited for the conversation. I'm going to turn the mic over here to Lori, who's going to walk through our agenda, and we'll dive right in.
Thank you so much, Tony. Hello, everyone. I'm Lori Houston-Floyd. I'm a manager with Medi-Cal Health. And as Tony said, part of the reason why I'm here today is over the past 2 years, I've been working with California's Department of Healthcare Services on their Medicaid transformation program. And today we're really excited to feature the work of 3 organizations who all operate in San Diego County, who are deeply involved in this work and who are endeavoring to provide social services to Medi-Cal members. So that's the story we're hoping to tell today. And if you can go to the next slide, just wanted to lay out the roadmap of how we'd like to spend the hour with you. So we'll probably spend about 10 minutes just providing a little bit more context. And then really the focus of our time today is to get to know our panelists, their organizations, and have a discussion about this very important work. And then at the end, we have about 10 minutes for dedicated audience Q&A. But as mentioned at the beginning, we really encourage active Q&A and specifically in the chat throughout. So Tony and I will be monitoring that, and we'll likely field questions that are coming in directly from the chat as well throughout. So I'm going to pass it back to Tony to continue to tee us up to have a successful panelist discussion today.
Thank you, Lori. We can go to the next slide. Risa, you can go to the next one. So most of you are likely already pretty familiar with the concepts of social drivers of health. And as you know, this year's conference is really anchored around promoting a deeper understanding of this concept and discussing solutions and how this targets health disparities. But just to make sure we're all working from the same common definition, as the slide sort of shows you, social drivers of health are the conditions in which people are born and grow, live and learn, work, play or worship, age, that have sort of a tremendous impact on their health. They can include things like accessibility of education and healthy foods, your job status, your social network, the income that you make, and safety in your community. As this slide illustrates, there are a number of studies in the US that estimate that the clinical care impacts approximately 20% of health outcomes, while the social drivers of health can account for as much as 50% of health outcomes. This is why we have seen over the last probably 5 years, tremendous interest among states, policymakers, providers, and payers in this space. So with this background in mind, it's also, I think, critical to understand how social drivers of health can contribute to addressing health disparities, inequities. So just a quick example for you, for people who don't have access to grocery stores with healthy foods, they are far less likely to have good nutrition and would be at greater risk of developing health conditions like diabetes. Recent, next slide. So this is now the role of states as we sort of set up here. Medicaid is the largest payer in most of the states across the country. It covers about 80 million people across our 50 states in DC. And in recent years, Medicaid, as I mentioned, has become a more active purchaser of services and interventions to address social drivers of health. We have seen a number of states become very active in this space, and in particular, over the last couple of years, states like California are sort of leading the charge at addressing health disparities through these interventions. So this is not surprising, right? Because if you are on Medicaid, by definition, you are low income and are thus likely dealing with circumstances in your life that very much can impact your health. I think also notably, Black, Latino, and other people of color comprise nearly 2/3 of Medicaid enrollees. And so when states are setting up their Medicaid programs to address SDOH, they are directly taking on and trying to reduce health disparities. Lori, back to you.
Thank you, Tony. So the next slide really lays out why California is so grounded and focused on investing in SDOH interventions. I'm not going to read the slide in its entirety, but just to pick out one specific statistic, you can see here that people who are Black make up 39% of California's homeless population compared to 13% of the state's general population. So that's staggering from just a health disparities point of view. But then when you think about the actual notion of being homeless, you can see that the SDOH impact of that is quite significant as well. So people who are experiencing homelessness have mortality rates 4 to 10 times higher than the general population, experience more frequent hospital stays, and have higher rates of chronic conditions as well. So clearly there's just so much work to be done in this space. And advancing to the next slide, you'll see the reason that we're able to have the conversation that we're having today is because of the state of California's deep and long-term commitment to transforming and strengthening Medicaid. I'm actually so thrilled to be joined today. I know listening are many of my DHCS colleagues who have been involved in this work for the past several years. And just to set the stage about the scope of this work, in California's Medicaid program, there are almost 14 million people covered. That's 1 in 3 Californians. And over time, the goals of this program are just so transformative. They're endeavoring to design a whole person care approach to health that address the social drivers of health. And one of the key goals, as you can see here, is to actually reduce disparities. There's not enough time today to really talk about how much effort and work is going on in the CalAIM space. It is just such a massive transformation. It comprises dozens of initiatives and programs, and thousands of people are working across the state to implement these changes. However, if you go to the next slide, I'm really excited to have a focused conversation about community supports, which is a piece of CalAIM that I've been deeply involved in for the past couple of years. And so what are community supports? These are a suite of non-medical services that are really designed to help address the social drivers of health. A little bit about the background here. California received approval from the federal government, from the Center for Medicaid and Medicare Services, to offer these services through their Medicaid program. California has the most comprehensive and innovative portfolio of offerings across the nation. And really importantly, let's just take a moment to talk about how these services are designed to work. So let's take medically tailored meals, which are exactly what they sound like. It's food. So the idea behind offering food as a non-medical service is that it will have tremendous impact if connected with the right person. So let's just take an example of someone who has congestive heart failure, they're food insecure. The idea is that by connecting this individual with a constant source of food, sending them food boxes for a period of several weeks or months, what sort of standard is like 3 to 6 months. The idea is that by making this connection, this individual will ultimately avoid high cost events like going to the hospital, going to the emergency department. Not only does this person's quality of life and quality outcomes improve, but also the insurance company that's managing this individual's care will likely see a reduction in cost and utilization. So really critically, the way that the program has been designed in California, the way that it's been authorized by the federal government, insurance companies have the option of selecting the menu of community support services that you see here on the slide. They're kind of darker in this dark blue area. There's 14 of them. And members have the ability to elect to receive these services as well. They're all optional. So what this means practically on the ground is that the insurance companies that are offering these services might offer different combinations of them. And that's just a current sort of design feature of the program. And I would be surprised today if our panelists didn't talk a little bit about this, because it does create some market complexity. The next slide, to just one final note of context before we get into our discussion, is around how individuals actually get connected with and receive community support services. This is probably the most innovative component of the design of the program, and that's here how you see on the slide, the Department of Healthcare Services, they're up at the top. They're designing the program, they're designing the eligibility criteria, then they're contracting with the insurance companies known as managed care plans. There's 24 of them in the state of California right now, and they're administering the Medicaid program. So then these managed care plans actually are required to contract with community-based organizations. So these are local government agencies, social service agencies, counties, so on and so forth. And it's really important because these organizations are actually in the community where members live, work, so on and so forth. And so with this background in mind, if you could advance 2 more slides, really just want to take a moment and introduce our panelists for today. So Raine, I'm gonna actually kick it over to you. If we could do a quick popcorn round of introductions, starting with you, and then we'll get into the dialogue.
Yes, absolutely. It's truly my pleasure to share this space with everyone today. My name is Raine Arndt-Couch, and I'm a Senior Manager of Social Services at Blue Shield of California Promise Health Plan. I may just reference that as Promise throughout the duration of today's panel. Glen?
Hi, thank you so much for having me. Glen Hilton, I'm the Director of Community Care for PATH in San Diego, and my pronouns are he, him, and his. Thanks for having me.
Hi, everyone. My name is Nancy Behm. I'm the Associate Director over our CalAIM program at PATH, and my pronouns are she, her. Passing it over to Michael.
Hi, my name is Michael Gennaro. I'm the General Manager of Pathway Home Solutions.
Thank you all so much. Okay, so I think in order for us to have a good conversation, it probably would make sense to just spend a moment and get to know each of you a little bit better in your organizations. So I think just to open us up, at least starting from the plan perspective, since the plan kind of controls the fate of what services are offered in a given county for this program, I'd love to start with you, Raine. If you could just tell us a little bit about Blue Shield Promise. Where do you operate in California? How many members do you serve?
Absolutely. Yeah. So Blue Shield Promise, as we've already talked about, is a managed care plan here in the state of California. We offer a menu of other forms of health insurance, but Medi-Cal is obviously our bread and butter here. We're contracted with the Department of Healthcare Services in San Diego, and also with the local initiative Health Authority LA Care Health Plan as a plan partner in LA to provide Medi-Cal benefits and services to our membership. Late breaking membership numbers that I got here from our January 2023 data. We have just under 139,000 members currently in San Diego County, and about just over 371,000 members in Los Angeles. And truly, when it comes down to it, Blue Shield of California and Promise, we're really committed to creating a healthcare system that's worthy of our family and friends, and that's sustainably affordable. That's kind of our goal.
Thank you so much. And can you tell us a little bit about the community support services that Blue Shield has decided to offer?
Absolutely. So we've taken a very aggressive approach. We're actually have elected to provide the full menu of services, all 14 that we had previously saw in a couple slides. But I'll point out that we are wrapping up some, various contracting to accomplish this milestone in 2023. But we're already actively providing at least 11 of these services in both counties. Asthma remediation is one that is currently up and running here in San Diego County only. So we're still working on that in Los Angeles. So just kind of pointing out maybe some of the differences between the counties right now. Also in the realm of supportive meals and medically tailored meals, we have actually an expanded menu here in San Diego where we're able to offer the more stringent medically tailored meals, and that would be tied to very distinct diagnoses, but also another tier of that, which is our medically supportive meals for folks that are coming out of the hospital, for example, to really help to get them sustained in the community and to avoid those rehospitalizations. We're also providing sobering centers here in San Diego County only, working on that contract in LA right now. But otherwise are servicing our members with our housing transition and navigation, housing deposits, and housing tenancy programs that you'll be hearing a lot about today with our partners, as well as our environmental accessibility adaptations, or better known as home modifications or home mods. So we'll really be highlighting those today.
So helpful. And can you actually just speak a little bit about the strategy behind why Blue Shield has invested in these services? And also what is the history here? Has the plan been focused on addressing SDOH to date prior to CalAIM?
Yes, absolutely. And the answer is yes to all of the above. But I think, for Blue Shield Promise, we've been committed and we remain committed to really building a quality network of providers, but also partnerships with our community organizations to meet the wide-ranging health-related social needs of our members. Historically, Blue Shield of California Promise was actually offering a menu of what was previously termed in lieu of services. So some folks may recall that terminology used even prior to CalAIM and community supports. So we were previously offering medically tailored meals, for example, recuperative care, shelter beds, as well as home modifications to our members. So we have a long-standing history of providing these services to our membership in partnership, of course, with our community providers. So as an organization, we really learned early on the value of these in lieu of services, or now community supports. And this really, I think, set the stage for our leadership to engage in expanding these services over time. And so CalAIM is really that platform for us to do this on a much larger scale. I'll also point out, and I may talk about this a little later as well, but we're staffed with a very robust field-based social services team. So I'm a medical social worker by background. My team is largely social workers as well as community health advocates. So what we learned historically, and we continue to learn even today, is that these staff members have that connection with our members, and they are able to source, what are the needs, assessing that clinically, as well as addressing those needs and identifying, where we need to make those investments as a health plan. And so I think that's really been an important piece as well in our community supports offerings, is it's really driven by our memberships and, our membership and our community needs specific here in San Diego as well as LA.
Thank you so much. So interesting to hear about the history that you've had with these programs to date, even prior to CalAIM.
Mm-hmm.
Okay, and I think let's now turn to PATH. Raine teed this up a little bit, but PATH, can you tell us about your organization, the history and the community that you've had, and sort of how the program has evolved over time?
Sure. So PATH was born in December of 1983 when 60 folks in Los Angeles met together to figure out what they could do to help people that were experiencing homelessness in their neighborhoods. And they started by just sharing food and clothing with individuals who were on the streets, and pretty quickly figured out that a street is not a home, and that we needed to do something to actually help move them into housing and get them stabilized in a setting that would be worthy of a human dignity. So today we've grown significantly. We now provide services in more than 150 cities in California in 5 specific regions. And we opened our San Diego region in 2013. So we're just coming up on 10 years of operating services here in San Diego. What we do is we help people find permanent housing. We provide shelter. We also provide medical and mental health care connections, case management, benefit advocacy, employment training, and a lot of other services. We try to help people move into their homes, and then we stay with them for an extended period of time to continue to provide supports so that they can remain stably housed. In the last few years in San Diego in particular, we've really leaned into the connection between housing and healthcare. We became a whole person care provider in 2018, where we were working with the high utilizers of the healthcare system in the area and really providing wraparound supports and services. And then in 2019, we became a health homes provider, which is another item that was also funded through Medi-Cal and through the managed care plans. Those two are the kind of the precedents for the CalAIM model, and really I think informed a lot of the CalAIM program design. And then in January 22, when the CalAIM program began, we were one of the early providers and transitioned virtually all of our clients from the health homes and whole person care programs into the CalAIM programs. For those of you who may have heard of whole person wellness, that's San Diego's term for whole person care. Whole person care is a term that's used statewide.
Thank you so much, Glenn. And You sort of talked about this, but if you could really clearly lay it out for our audience and go slowly, because this is complicated. Can you describe which community support services you offer? And can you really talk about what each of them are and help define what they are and what they mean?
Sure, I'll let Nancy take that.
This one's me, my bread and butter at this point. So we are offering 5 of the 14 community supports. And in layman's terms, for recuperative care, that's one of the services that we provide. I like to think about this as providing a dignified discharge from a hospital, where like someone with a home would be lounging on the couch, watching Netflix and trying to rest and recuperate. Folks on the street don't have that option. We also leverage this as an opportunity to avoid hospitalization. Hospitals can be really traumatic, and hospitalizations can be really traumatic for anybody, but particularly our folks. So we'd like to avoid those as best as possible. And that's actually something that we have been working with Blue Shield on prior to CalAIM as well. So we've been a longstanding partner on that. And then there's also short-term post-hospitalization housing. And this one is essentially creating like a bridge, buying time to find permanent housing post-discharge from an institution. It could be a hospital or a recuperative care stay, or if someone's exiting, substance use treatment program, that can be an option. And it's up to 6 months stay in our shelter or with any of the other service providers in the county to give time to find permanent housing, because it can take at least 6 months, if not more, for our folks. We also offer what I like to call the housing trio. So it's housing transition navigation services, housing deposits, and housing tenancy sustaining services. And so the first one is really what it sounds like, navigating the housing market, navigating the barriers that are in the way of folks obtaining housing. And because that takes so long, what I talk to my staff about is we're working on addressing anything that will get in the way of them getting housing, but also let's try to be preemptive about what might be a barrier to them maintaining that housing. Whether it's behaviors, budgeting, who even knows what might come up. And then there's this beautiful thing called housing deposits that I love, and it's one-time access to funding of up to $5,000 for move-in expenses. So we're using this for security deposits, first and last month's rent, first month's utilities, and then the part where it gets really fun is if there's money left over, we will help furnish their unit. And that's been really fun to make a home, rather than not just moving them indoors, we're making a home and really, buying cleaning supplies, furniture, bedding, etc. And then if we have money even after that left over, we're gonna tap into buying 2 weeks worth of groceries for folks, which, grocery prices are insane right now. And so EBT only goes so far. And so we've been really excited about that one. And then the final one is housing tenancy. And this is for, we've been leveraging this for folks who, being back in 4 walls will be really, really tough. Folks who have been chronically homeless for a very long period of time, who, being isolated in a unit by themselves could be really overwhelming, or we think, there could be increased substance use or risk of overdose, or even just challenges with being a good tenant and of being a good neighbor. Those are the, when we've been leveraging that one, it's usually in those situations. And that one's also once in a lifetime. So we try to be thoughtful about the use of that. But that's really how we've been going about those.
Thank you. So helpful to understand the range of services that your program offers. And I think this is a really nice moment to now turn to our final panelist, Michael, with Pathway Home Solutions. I think we'll immediately get a sense for the range of community support services and the different patient populations that they reach. And so, Michael, would love to turn it over to you for a background on your organization and the members you serve.
You bet. Thanks, Lori. So Pathways Home Solutions was founded in 2021. We work really closely with all the various CBOs that are out there, as well as private insurers who can utilize our services. We center our services around environmental adaptations and primarily accessibility home modifications. So that means like installing grab bars, ramps, toilet risers, floor transition strips, things that really may not be very glamorous, but are things that people who are aging in population in general, and then also who are dealing with the byproducts of those social determinants of health and sickness and whatnot, they're able to stay in their home longer. They're able to live better while they are in there. And so that's the main service that we provide is centered around those items. So for us, we also see that not only is there a benefit for the members who are taking advantage of these products, but also for insurers as a whole, they're able to see lower costs over the long term, because the risk of slipping and falling is lower. The risk of not being able to live healthily within those social determinants of health, their quality of life is improved significantly by having these adaptations inside of their home.
Great, so helpful. And I think just to draw this out for the audience a bit more, can you talk about some of the other sort of problems that you're solving for as an organization? You mentioned it, aging in place, but I don't know if you have any other kind of data or examples that you wanted to highlight for us.
I wish I had a big, great set of graphical information, but basically, we're still a young company. So being that we started in 2021 and the plan usage really started in 22, there are the people who are most excited to hear about these tend to be the administrators at the top of the plans, because they can immediately justify in their minds what the cost of these environmental adaptations are versus the long-term cost of that care if somebody is ultimately injured from it. So I wish I had a lot more data to share, but unfortunately it'll be next year's panel. We'll have a lot more good stuff to share.
Great, thank you. Okay, so I think that we now kind of are situated in the realm of CalAIM and some of the community support services. So I'd like to have a bit of a broader dialogue. And let's talk about member engagement. Let's start there. Let's just pause it and share with the audience. It'd be very interesting to hear about how you actually go about engaging and connecting with members who are in need of these services. I imagine it would look different for each of these organizations. So Path, I'm actually going to turn it back to you and have you kick us off here.
Yeah, so I would say we receive referrals in all sorts of different pathways. We certainly had a lot of grandfathered members in, which filled up our caseloads pretty quickly off the bat. But we receive referrals through the health plan. So they might get them from a healthcare entity or other service provider or whatnot. But once we have that referral, or we receive referrals internally through our other PATH programs, we're leveraging phone. Telehealth has been a huge help for us. And in instances where we can't get in touch with a member, or they don't have a phone or whatnot, we're leveraging all the systems that we can to try to locate them. For those familiar with Clarity, that's the homeless management information system. And so if someone's in a shelter, they'll be listed there. And so we'll try to find them. But for the most part, if a member does not have a phone or they're not in that system, it can be really challenging. And so this is where having information on like common street corners or areas that clients are residing can be helpful for us to try to locate and engage folks that way.
Thank you. And Michael, just so curious about how your organization receives referrals.
Sure. So we work with Raine and her team, community supports for both San Diego and Los Angeles counties. They have a multitude of caseworkers that are in the field that are engaging with members directly in their home, just part of regular services with them. And then what we do is we have done trainings with Promise and the staff on these teams to encourage utilization, right? Introduce our services, show them the benefits of it. Ultimately, the members benefit, because these are typically people that are not able to afford large modifications to their homes, and so by this being provided by the plan, it makes a real big difference very quickly for a lot of these people. And I deal with almost all of the outreach myself personally, so when I get a referral from Raine and her team, I call the member, I tell them who we are, I also, make the appointment for when we go in and do our, what we call our pathway 360-degree assessment, where we look at the inside and the outside of the house. We then, get a recommended scope of work over to Promise, and the team there gives us a authorization to do the work if it meets the criteria. And so, yeah, for us, I think we're also in that place where everybody who I call is beyond thankful, because many of them have medical conditions already and don't, I get this a lot, where people are just overwhelmingly happy that somebody is doing something for them that they need very, very deeply, right? And that part's super rewarding. But I think also, we're also trying to do it where we are really trying to reach out to both because the case managers do so much of the referral work for us. We also want to make sure that we're providing really, our outreach tends to be primarily towards them in this particular instance, as opposed to individuals. But we had our weekly call today with the leadership team at my company, and we're kind of talking about what maybe our possibilities are for direct outreach in the future, so that more people are able to understand that this is offered.
Thanks, Michael. And just a follow-up sort of clarifying question, it sounds like your team is actually engaging with members directly before the service is even authorized from the health plan. You're engaging in sort of an initial assessment of the home. Is that right?
Yes, that's right. And I would say that this is probably one of the areas where home modification has maybe not been at the forefront for most of the CBOs, because there are a lot of questions around this, right? So the places that we go can be mobile parks, they can be apartment buildings, they can be homes that are owned by other people. So you have this question around, like, who else do we have to get involved for an authorization to install a semi-permanent structure at that person's home? And in some instances, it requires permitting, and that's a whole nother subject that we have to get into separately. But yeah, so that's a big component out of it as well, is being able to handle sort of a very kind of a unique instances where people are living in other people's homes.
Okay, thank you. So we've heard about sort of member identification and member engagement from the actual provider point of view, but I'm curious to hear about it from the plan point of view. Raine, are you using data at the health plan, or can you talk about all the mechanisms or ways in which you're doing member identification and supporting referrals?
Yes, absolutely. And I will caveat this with the fact that we're continuously trying to refine our ability to what I call like case find, right? Being able to use our data that we're collecting to tell us, which members might be more at risk or might benefit for specific community supports. We're definitely leveraging that in the arena of medically tailored meals, I would say, because those are based on very specific diagnoses. But otherwise, it really harkens back to, as I mentioned, our robust social services team, really, as they get referrals for various social drivers of health needs, typically things like transportation, things like food insecurity, that they're then doing a very comprehensive assessment of those needs and beyond. We know, right, that if someone has food insecurity, that's sort of one of those, not maybe gateway isn't the right word, but we know that we're going to likely expect other health-related social needs that will come from that as well. And so we're constantly scanning for that and being able to educate our members and frankly, our partners, right, that refer members to us about the wide variety of places that we might be able to fill those gaps. So again, our social workers, our community health advocates are out in the community, they're doing telephonic work, but we're also really engaging internally at Blue Shield Promise with our case management teams, our nurses, our quality teams that might do some work with other partners. For example, Vista Community Clinic, there's some work being done there, and we identified a pathway towards medically tailored meals just from that relationship. So we're really at this stage starting to ramp up our ability to identify all the various pathways, and we want to make sure that there is basically no wrong door. So any place that our members are being touched by a provider or a community-based partner that we might have, or one of our internal staff, that it's on the top of everyone's mind, and it's not just that social services are the only staff members internally that can refer, but really that we need everyone thinking about this and getting folks connected to services. Of course, our team will actually help connect them and do those comprehensive assessments, but we're really getting the word out across the board to improve referrals and utilization.
Thank you so much. And so once you all have your members that have been identified, services have been authorized, it would be helpful to kind of hear about the different care teams and care models that exist to help engage with members. And so, Path, going back to you, once you have the member, how do you start working with them, and what is your care team approach like?
Yeah, we have a number of different staff on the navigation and tenancy side, including a case manager that the client will be working with, a peer support specialist who has lived experience, whether that's with homelessness, substance use, incarceration, mental health, you name it, and a clinician as well to address like crisis intervention and be a bridge support for mental health services. And a housing specialist who is more externally facing, trying to convince landlords to give our folks a chance. And that kind of comprises our team structure. And then for our recuperative and short-term post-hospitalization, there's one case manager who's providing support or case management services to those folks, although they're kind of part of our larger shelter structure. And so we have 24/7 coverage and support there.
Thank you. And Michael, same question for you.
Sure. Yeah. For us, we, like I said, I do a lot of the initial outreach for the referrals and making appointments and doing our quality control. And then also we work really hard with our technicians to make sure that people are well-dressed, well-groomed. They come in with professionalism, that we work really hard at establishing that, because for all this work, it's super important to put on that air of not only kind of accountability, but also professionalism. That's something that we bank on very highly, and especially because when you are dealing with this sort of sensitive thing where it's a very intimate environment, you are in people's homes as closely as you can imagine, right? Everybody who's got dirty laundry sitting in the corner of their house, imagine that at all various different levels, right? Sometimes we see things that are downright scary, and then other times we're not. But yeah, that's a big component of what we do, is being able to ensure that our folks are treating everybody with professionalism out in the field, because it's not always the way that it goes in construction and building. So it's a central tenet for us.
Thank you. I want to acknowledge the chat is kind of blowing up, so I want to get some of these questions in as well. And there's a really interesting question about eligibility for the homeless services that you offer, Path. Can you talk about, so Elizabeth asks, are these programs available for low-income, disabled homeless seniors without dependency or behavioral health issues? I'm wondering if you could shed light on that.
Absolutely. So, I mean, anybody who is with a CalAIM managed care plan that sponsors these community supports can access these services. And this is actually what I think is the most beautiful part of the CalAIM program. Is for years, we were bound by contracts that limited how many people we could serve and how many staff we could hire. But with CalAIM services, we are able to right-size staff in order to expand as the need is present, so that we can actually serve really an endless number of individuals as we grow with the client population. There are no other prerequisites as far as age or anything like that. They do have to have some, general chronic health conditions, and Raine can probably speak most accurately to that.
Yeah, I think that's actually a highlight of what CalAIM and community supports is really allowing us to do, is to pull back some of that red tape, I'll say it, right, and for lack of a better term, but really allows us to get these services to folks that need it, knowing that they are huge gaps in our community. And to date, we really haven't had the mechanism to be able to fill them. And so being able to elect and offer these services is, you know, for my social work heart has just magnified our ability to actually intervene, right? To provide interventions that are targeted to these needs that we really, prior to this, were struggling to be able to provide. So
I will say
there are criteria, but, you know, again, we're really look to be expansive as possible with those.
right, and I was going to mention specifically with the recuperative care and short-term post-hospitalization housing, there are some very specific conditions under which individuals qualify for those, you know, related to hospitalization or prevention of hospitalization, depending on the benefit.
Thanks for covering that. I want to turn now to the impact that you're making. So if you could talk, just illuminate for us how many members that you're able to serve on a given month, just to understand kind of the scale of your work would be really helpful. Michael, I'm not sure if you want to start us off.
Sure. As the salesman in me says, there's an unlimited number of people that we can handle on a regular basis. We don't get we get anywhere from 5 to a dozen referrals in a week from our various partners around Southern California, San Diego, and LA counties. And then we also have contracts for service in Northern California, and we get some from that as well as from the Central Valley. We are a nationwide company, have abilities in all jurisdictions across the country, I would say, through our partner network, but we so far have only been operating in California. So that's from our perspective, the work that we do, it's mostly around coordinating schedules with people. That's the biggest logistical hurdle that we have. The installations, the assessments, a lot of time for the work that we are doing, the assessment, it takes more time for our technicians to drive to a location to do the assessment itself, right? So that's part of it. And then once we also do the actual work, depending on complexity, if we're doing a grab bar installation, tends not to be too terribly long as well, but we also have like ramp installations. Those take time, a much bigger amount of time and planning. And so, like I said, we're basically, I try to be supremely responsive. I'm from an industry where, if you show up when you say you will, you have probably a 90 to 95% hit rate in terms of being able to get work continually. And that's really, what we strive for, is just being able to show up on time consistently. But we, as we ramp up, we are constantly talking to our partners about potential increases in business. And so they're always really, really thankful about that, because ultimately these are working people who are out there, and their job is to do installations and put things in. And in this industry, that's the thing that we like to do. And it's just kind of an added bonus that we're helping people in that instance. But yeah, everybody is, it's sort of one of those industries where you go where the work is. So as long as there's more things coming, we try to be supremely responsive to being able to handle it.
Great, thank you so much. So it sounds like things are ramping up, but 5 to 12 referrals-ish a week is kind of your average at this moment in time.
Yep.
I'm curious to hear how that may or may not compare with PATH in your program.
So, as I alluded to a few minutes ago, the number of clients we can serve is really directly tied to how many staff that we have performing the services. And the current job market obviously makes it challenging to ramp up and to retain staff. So we have, since the beginning of CalAIM, served 283 individuals through our CalAIM services. We currently have 144 enrolled as of the last count that I had. That is actually a little more than our capacity at the moment because of some recent staffing changes that we've had. But of course, once they're enrolled with us, we continue to find a way to serve them. So our case managers are certainly working as hard as they possibly can right now to make sure that the quality of care doesn't decline. Our goal right now in the short term is to get to 200 individuals that we can serve per month. And by the end of next year, we're hoping to get to 300 individuals per month that we're able to serve. There also have been a lot of changes with the health plans in the past few months. We started contracted with 6 health plans at the beginning of CalAIM. We're now working actively with 3 of them. And, as we know, there will be some shifts coming up in terms of health plans that are available in the county starting next year.
Thank you so much, Glenn. I know there was a bit of dialogue about that in the chat too, with the procurement that's live and active. And so, Raine, I'm going to actually now turn this question over to you, and I'd love for you to answer it in whatever way it makes sense. I don't know if you want to report out sort of on global numbers of members served through the plan, or I know you offer a lot more community supports than we're talking about here this evening. So just curious to hear how you're thinking about members served.
Yeah, I mean, I think year one, when you look at the raw numbers, you kind of go, that doesn't seem that many. I think across both counties, we processed about 2,000 referrals last year. At the end of the year, we were at the stage where we were getting at minimum 100 referrals per month, kind of give or take, with a larger bulk, of course, in Los Angeles County, just because it's a larger membership there, but we're steadily increasing. And again, I think it goes back to that strategic plan that I alluded to, which is really to ramp up our education, both member facing as well as internally and with our community-based partners and beyond, just getting the word out. So being here today, for example, is a huge step, right, in making sure that people are aware that these services exist. So we are definitely planning to see an increase in both referrals as well as utilization over time. And a large part of that is to continue building our networks, our connections with our organizations and our our partners that we are already engaged with, and just continuing to build capacity. I think that's similar to what Glen's mentioning is these are new services. We didn't fully know what to expect, although we knew that it would be good, right? The outcomes are good, but how do you plan for the volume and whatnot? And now that we've had year one under our belts, I think we're all much more focused on how we build that capacity and build the engagement over time. So we're excited for 2023, that's for sure.
Thank you. I want to note the time. We have about 8 minutes left, so please keep putting your questions into the chat. This dialogue, there's so much to discuss with you all. You've talked a little bit about this thematically about year one, and it sounds like general theme here is that everyone is ramping up and wants to increase the overall number of members served. I'm also just curious if you would like to offer reflections on year one of this program, both challenges as well as successes. Path, I'll start with you.
Nancy, do you want to talk about the successes first?
Yeah, we can start on a happier note. So we've had 61 folks move into permanent housing this year, which is incredible, especially given how challenging and complex the San Diego housing market is. With that, getting into slight challenges, which Glen will mention, right? There've been closures of lower income or more affordable housing. So I'm really proud of my team and what we've accomplished, and ending stories of homelessness for folks. And then, as I was, geeking out about housing deposits earlier, but it's been really fun having move-ins where we can actually furnish units. There's the nonprofit space, and certainly in the homeless sector, we have limited resources and we're bound by contracts. And so this has been a really fun and enjoyable way to celebrate move-ins with clients. They've shared with us that it's just been a lot more exciting than just, kind of this overwhelming sense of getting keys and now they have all these responsibilities. Well, now we can kind of furnish their unit and get them excited about being indoors again. And so I'd say those are kind of our main two ones on the navigation tenancy space. And then for recuperative care and short-term post-hospitalization, we've been working on increasing our utilization, but just the number of clients that we've been able to care for in that space and provide, a dignified place to recover or recuperate. Any number in that category is going to be a great outcome in my book. So it's just been really great partnering with the health plans, and we're looking to increase and care for more folks in that space. Glen, now you get to have the fun job of challenges.
Well, I noticed Nancy dipped her toe into the challenges just a little bit, so I'll start with what she mentioned, and that is just the lack of low-cost housing in the area is going to continue to cause a challenge for housing San Diegans that are currently unsheltered. And that unfortunately is not going in the right direction right now, as we're seeing some of the lowest cost rental units going off the market because SRO owners are refurbishing, redesigning, repurposing, or selling their properties. So that's going to continue to be a struggle, and we're getting as creative as we can to find solutions to work around that. Another challenge is that the rental rates of even the lowest cost housing are still high enough that for individuals who are disabled, who are on fixed income, they are severely rent burdened, sometimes paying 80 to 90% of their income on housing, which is not sustainable. That's not something that they're going to be able to do long term and remain stably housed. The absence of any particular rental assistance, because Medi-Cal can't include ongoing rental assistance as part of the program, we are always looking for ways that we can leverage other resources for rental assistance for those individuals that need it. The county just announced a pilot program that will help with that and so forth. But that's part of the challenge, is trying to line up the resources that will make sense for individuals to be able to actually pay their rent on a consistent basis without fear that 6 months from now they're going to re-experience homelessness.
Thank you so much, PATH team. Michael, over to you for year one challenges and success.
Sure. I mean, I kind of talked about it a little bit. I think everybody here can kind of empathize, right? Everybody here knows someone who is a parent or an aunt or an uncle or a friend who just has, they're older, they have health issues that impact their mobility. And just imagine, being able to provide something to them. On top of this, like I said, these are people that have typically lived with medical issues for long periods of time. And I do get the feeling from some people that, that definitely impacts their mental health as well. And so you have people that maybe have some element of depression in their life or some other, component like that. And so to go into a home, to make that modification and be this company and the person for that matter who goes in and does it and makes this enhancement of their life, I get so many. I mean, that is easily the best part of this job for me, is the happiness you get when you go on, you make a QC call to somebody, or you go out in the field and you check with this person and you see the work that's been done. I won't say I've had people break down in tears, but I have had people just thank me profusely. And like I said, coming from a construction and development background prior to this, you didn't really get that, right? It was very few and far between when something like that happened, if ever. But here it is overwhelmingly what you get back, and that is a wonderful feeling. And I will say that is also something that maybe doesn't get all the notoriety that it should, or becomes a bit of a platitude at certain points, but it really is the truth. It's a wonderful thing that we get to observe on a regular basis. That's probably our best thing from this past year.
Thank you, Michael. And Raine, would you like to close us out?
Yeah, I know we're really coming up on time, but I think both PATH and Pathway have really highlighted that we're all here for the same purpose, right? The goal is to care for our members, our shared members and clients. And really what that translates into is strengthening our community, right? Our ability to improve health and wellness of a few individuals in a larger community is going to just strengthen the entire community. And so I think for us, it's really been the ability to partner with strong organizations that are on the ground, boots on the ground. Even though we have social workers that can go out into the community, we don't have access to the same level of expertise or resources that our community-based organizations do. And so working together, we are just that much, it magnifies again our ability to serve our membership, make sure that we're filling the gaps that we know are there, and ultimately, pushing forward on our health equity strategies as well, because this is what we're here for, right? We need to provide healthcare, and healthcare meaning the whole person. And so I think that's the highlight. Of course, there are administrative challenges, but we're working through them. And again, those are our ability to do that is because of our strong partnerships with our partners and our providers.
Thank you all so much and for sharing all about the great work that you all are doing. And I just know we're about to run out of time, but I did want to acknowledge one final question in the chat that came from Paula, thanking everyone for the session and wondering if there are any opportunities to volunteer.
I can speak on behalf of PATH. We absolutely do. We have a community services director who is, that's one of the major tasks is to really help connect volunteers and donors to opportunities to provide goods, services, just about any way that they might want to.
Great. Thank you all so much for your time today, and for everyone who joined. Thank you for the dialogue and the opportunity to share the CalAIM story with you all.
Thank you.
Thanks a lot, everyone. Thanks, Lori.
Thank you.
Thank you.
Thank you all. This has been absolutely wonderful. And I know that these are conversations that start today, but are going to continue. This is generative and incredibly insightful. So again, thank you all panelists for your time and expertise and insight into providing, necessary care and care with dignity to the San Diego community. It's really a significant space. For the rest of you attendees, again, thank you so much for joining us today. We encourage you to continue to participate in the sessions this afternoon, as well as tomorrow down at UC San Diego Park and Market, where we will have a number of in-person sessions. We also have a number of ways for you to stay really involved. We are always looking for, if you are interested in staying connected with alumni, such as that are on this panel, opportunities to be a panelist in the future or to mentor current students and other alumni. You can sign up today at Triton's Connect. We also have our Alumni Celebration Week, which is an opportunity to have alumni from all over the region, the state, the country come back to UC San Diego and really celebrate all of the accomplishments, such as what you're hearing about today, and even more, all together in person. And then we will also be having our Day of Caring, which is our Day of Giving in May. So again, there's so many ways to stay involved and engaged in this important interdisciplinary work. And so we just really appreciate you being here today, and we look forward to seeing you in the future. Thanks again, panelists, and have a wonderful rest of your day. We will see you all soon.